Welcome. I am Dr. Ariana Lewis. I'm a generalist in obstetrics and gynecology here at UT Health San Antonio. Our presentation today is Building Trust, Restoring Hope, the Power of Trauma-Informed Care. We'll explore how trauma-informed care allows us to build trust, restore hope, and create spaces of healing while preventing re-traumatization. This approach isn't about adding something new, but about changing the way we do everything, changing our approach. My hope is that this will change your approach to care and your view of so called difficult patients or difficult interactions. I have no financial disclosures. Our objectives. Today, we want to understand the principles of trauma informed care, develop organizational policies that incorporate trauma informed principles to ensure supportive environments, and utilize language and approaches that avoid re traumatization. So, what is trauma informed care? Trauma informed care is healthcare and social service is an approach that acknowledges and respects the broad impact that trauma can have on individuals. With trauma informed care, we have a goal of preventing re traumatization while also promoting healing and resilience and recovery. This is grounded in understanding that there are many different experiences that contribute to and result in trauma. These experiences impact people every moment of their lives. Interpersonal interactions, engagement in medical treatment and services, and response to stress, just to name a few. The goal of trauma informed care is to emphasize empowerment, safety, and cultural humility. We want to shift the focus from what is wrong with you to what happened to you. We want to incorporate our knowledge of trauma and its impact into policies and our everyday practice. Although our focus is medicine today, this extends to basic social interactions as well. So, trauma has a very broad definition. Trauma is any deeply distressing or disturbing experience that overwhelms an individual's ability to cope, disrupts sense of personal safety, and has long-lasting effects on mental, physical, emotional, psychological, and social well-being. Now, this is very broad and comprehensive for many reasons. For one, trauma can result from a single incident, repeated experiences, or systematic oppression. Again, it overwhelms a person's ability to cope, leaving lasting effects on mind, body, and relationships. So trauma is determined by how one experiences and interprets the event, not simply the traumatic event itself. Two people may experience the same car accident. One may recover quickly without any lasting trauma, while the other develops lasting fear, hypervigilance, or PTSD whenever they're in a vehicle. The event does not have to be extreme either, such as PTSD from wartime or physical assault. Any stressful event that impacts someone falls into this category of trauma. Again, trauma falls into a few categories. We have acute trauma, chronic trauma, complex trauma, and secondary or vicarious trauma. Acute trauma, this is a single incident that is overwhelming, such as a car crash, an episode of assault, or a natural disaster. Chronic trauma refers to repeated and prolonged exposure to stressful events, such as ongoing abuse, not just a single episode, neglect, bullying, or domestic violence. Complex trauma refers to exposure to multiple or prolonged traumatic events, often interpersonal, like beginning in early life, like childhood abuse or living in a violent environment. Lastly, secondary or vicarious trauma is trauma experienced indirectly, such as through witnessing another person's suffering or caring for traumatized individuals. This type of trauma is common in healthcare and social work professionals. So, what domains are affected by trauma? So, we have both emotional and psychological. Think anxiety, depression, dissociation, hypervigilance, shame, and guilt. We have behavioral, avoidance, aggression, self harm, substance use. Physical, somatic symptoms, chronic pain, an altered stress response. Social domain, difficulty trusting others, social isolation, challenges with intimacy and attachment, developing relationships. There's also an impact on functioning that occurs. Trauma can alter brain development, stress regulation, and coping mechanisms. It affects how individuals perceive safety, interpret interactions, and respond to stress, which is why trauma can influence engagement with healthcare, social services, or education, making this pertinent to the care we provide. It is important to consider that trauma includes experiences of systemic and historical oppression as well, such as racism, sexism, colonization, or displacement. Trauma informed care recognizes that such trauma can be collective and is not only individual. Prevalence of trauma in populations relevant to trauma informed care is high and oftentimes under recognized. This is why trauma informed care is considered essential in healthcare, social services, and educational settings. Trauma is common across all ages, genders, and socioeconomic groups, but certain populations are disproportionately affected due to, due to factors such as poverty, systemic oppression, or exposure to violence. 70 to 90% of adults have experienced at least one traumatic event in their lifetime. Common traumatic experiences include physical or sexual abuse, witnessing domestic or community violence, serious accidents or natural disasters, and sudden loss of a loved one. Trauma is widespread. The ACEs study revealed that most adults have experienced at least one adverse childhood experience, or ACE. Trauma is not the exception. Unfortunately, it is the rule. It is important to acknowledge the ACEs. So, adverse childhood experiences are early life traumas that can have lifelong impacts on brain development, stress regulation, and physical and mental health. ACE studies show that about 61% of adults report at least one ACE. About 16% report four or more ACEs, which are strongly associated with chronic health conditions, mental illness, and risky behaviors later in life. ACEs include abuse, neglect, parental substance use, mental illness in the household, and domestic violence. The more ACEs a child experiences, the higher the risk for poor health and social outcomes. This is called a dose response relationship. Healthcare setting. So, trauma is highly prevalent among patients seeking healthcare, especially in primary care, mental health, and obstetric settings. It's estimated that 25 to 50% of patients in primary care or mental health clinics report a history of trauma. Among women receiving reproductive or obstetric care, up to 60% report prior trauma, 25% report active trauma during their pregnancy. This includes sexual assault or intimate partner violence. Trauma history often contributes to avoidance of care, non adherence to treatment, and heightened stress responses during medical procedures, highlighting again the importance of trauma informed care. Individuals in certain contexts experience trauma at much higher rates, including survivors of domestic violence, sexual assault, or human trafficking, again, obstetric patients, homeless populations, with estimates of 50 to 80% having traumatic histories, individuals in the criminal justice system, they have high rates of prior abuse, neglect, or community violence, and lastly, refugees or survivors of war or displacement. So, implications for trauma informed care. The high prevalence of trauma means that most organizations and service providers are likely working with trauma affected individuals, whether or not they are aware of it. Trauma informed care shifts the default assumption. So instead of asking, does this person have trauma? The assumption is that trauma may be present and should be considered in all interactions. This approach promotes safety, reduces re traumatization, and improves engagement and outcomes. As you can see in this image, there are many forms of trauma that can impact our patients: verbal, physical, and sexual abuse, neglect, both physical and emotional, domestic violence, substance use disorder, divorce, mental illness, and incarceration of family members. We would not know about any of these traumas by just looking at a person, but we must be aware of the potential for their presence. Trauma shapes the way people experience the world, altering biology, health, and relationships. Behaviors we see may actually be survival strategies in our trauma survivors. Trauma can manifest in many ways across emotional, behavioral, physical, cognitive, and relational domains. These manifestations are often subtle or misinterpreted, which is why a trauma informed approach emphasizes awareness, sensitivity, and a non judgmental understanding. In the following examples, consider how you would normally respond to these situations versus how you would respond to as a practitioner who provides trauma informed care. So, first is emotional manifestations. Trauma often affects emotional regulation, leading to anxiety, fear, hypervigilance, depression, sadness, persistent hopelessness, irritability, anger, sudden mood swings, feelings of shame, guilt, or worthlessness, emotional numbness, detachment, or difficulty experiencing positive emotions. I think we have all seen these in our patients. So an example in patient care. A patient may appear withdrawn or have a flat affect during a clinical encounter because discussing their history triggers overwhelming emotions. Normally, this may make us upset, it may make us frustrated because it's difficult to get a history when we're trying to complete our documentation in a timely fashion. But we should have a different approach, right? Because we don't know what type of trauma this patient has experienced that is making them respond in this fashion. What about behavioral manifestations? So, trauma can influence behaviors in ways that may seem challenging or non compliant. Maybe patients are avoidant of situations, people, or topics that remind them of the trauma. They may be aggressive or oppositional in their behavior as a defense mechanism. There may even be self harm, substance use, or other coping strategies. Patients may have difficulty following instructions or adhering to treatment plans. Overreaction to perceived threats or criticism may also occur. So, an example in care: a patient may cancel appointments or refuse certain procedures due to past medical trauma or distrust. So, maybe we see these procedures as extremely important, absolutely need to happen, but the patient sees it as you being demanding or relating to a prior trauma. So we must reframe and figure out how to better approach that when we're considering patients in the realm of trauma informed care. Cognitive and mental health manifestations. So trauma impacts our thinking, attention, and memory. We may have difficulty concentrating or making decisions. There may be memory gaps, flashbacks, or intrusive thoughts, persistent rumination or hyper awareness of potential threats, disassociation or feeling disconnected from reality or oneself. A patient may have trouble providing a coherent history during intake or seem spaced out during discussion of sensitive topics. If we are not providing trauma informed care, maybe we're frustrated and annoyed and maybe think our patient may be on substances for this spaced out appearance, but this also may be a coping mechanism for our patients who have experienced trauma. Well, physical and psychological manifestations. So, chronic trauma can affect the body in many ways. We see somatic complaints like chronic pain, headaches, GI issues, and fatigue, exaggerated startle response or hyperarousal, sleep disturbances, nightmares, and insomnia. There may be changes in posture, tension, or physical withdrawal even. A patient may experience panic and or a flare-up during routine procedures due to triggers associated with past trauma. These may manifest themselves in a way that would not typically occur in a routine procedure or exam. So again, trauma changes not only experiences, but the way that people perceive the world. Relational and social manifestations. Trauma significantly impacts trust, attachment, and social interaction. Patients may have difficulty trusting providers or any figure of authority. There is fear of rejection or abandonment, which many trauma survivors have experienced, difficulty establishing healthy boundaries, and then also social withdrawal or isolation. An example, patients may hesitate to share personal information or appear guarded in interactions with healthcare staff. They're trauma responses. Many of these manifestations are adaptive responses to prior trauma, even if they appear maladaptive in the current setting. We have a fight response, right? Anger, aggression, irritability. Also, the flight response, avoidance, withdrawal, running away. And then the freeze response, right? Dissociation, numbness, or immobility. That, recognizing these responses is central to trauma informed care. It helps providers respond with empathy, validation, and strategies to promote safety and the patient being in control rather than punitive or confrontational approaches, right? So remember, we asked how you would normally approach a patient in these situations versus what a trauma informed care response would be. So we have to, as providers, take a step back and reevaluate before we approach patients in these situations to ensure we're providing trauma informed care. And then there's subtle or hidden manifestations. Some trauma effects are less obvious, but equally important. So, difficulty trusting one's own perceptions or decisions, thinking they may have led you astray in the past. Overachievement or perfectionism as a coping mechanism. I think we've all seen that. High sensitivity to criticism or perceived judgment, and a reluctance to engage with services or follow guidance. So trauma informed care shows up in every aspect of a person's experience. I think recognizing these manifestations allow providers again to create safe environments for their patients and develop strong rapport, and avoiding re-traumatization and improving patient engagement and outcomes is the overall goal. So trauma is not always visible, and its effects can persist long after the traumatic event has occurred. We have to shift the perspective, right? So the traditional approach is to say, "What's wrong with you?" Whereas the trauma informed care approach says, "What happened to you?" This is the heart of trauma informed care. Reframing our response. Instead of judgment, we bring curiosity and compassion. Providing trauma informed care requires a fundamental shift in how we view patients, clients, and even our colleagues. It focuses on understanding behavior and needs in the context of trauma. So here's how this perspective shift works, right? We have to go from blame to understanding. Normal approaches may see challenging behavior or noncompliance as defiance, whereas trauma-informed care approach sees this as adaptive responses to trauma, right? So maybe a patient who refuses a procedure, they might be expressing fear rooted in prior medical trauma. It may not be a case of stubbornness. Shifting from individual deficits to strengths and resilience. Instead of focusing solely on pathology, trauma-informed care emphasizes strengths, coping strategies, and resilience. Providers should look for what has helped the person survive rather than just what's wrong. Maybe a patient who's hypervigilant may be seen as having developed strong alertness to threats, which can be redirected in positive ways. Shifting from punitive or controlling approach to collaborative care, right? So, trauma informed care prioritizes shared decision making and patient empowerment. Patients are treated as partners in their care and given choices and autonomy whenever possible. This allows a patient to choose the timing or method of a procedure to reduce stress and ultimately build trust with the provider and the medical care system in general. Shifting from a focus on symptoms to a focus on safety and healing. We should emphasize creating physically and emotionally safe environments. This includes considering triggers, avoiding re-traumatization, and promoting predictability and consistency. Explaining each step of a procedure before it happens, providing privacy, checking in with the patient's level of comfort. All of those things are vital in providing collaborative care. Shifting from isolated interventions to system wide awareness. So, trauma does not only affect individuals, but also systems and communities. So, trauma informed care encourages policies, procedures, and staff training that recognize trauma as pervasive. Hospital adopting trauma informed policies for all staff, not just for mental health providers, is an example of such. And then shifting from short term fixes to long term support. Trauma informed care recognizes that trauma's impact is ongoing. Care should be continuous, patient centered, and supportive rather than episodic or transactional. So, integrating mental health support, peer support, and follow up into chronic disease management would be example of this shift to long term support. So, this perspective reduces stigma, encourages engagement, and opens the door to having healing relationships. The shift to a trauma informed perspective matters because it fundamentally changes the way that care is delivered. It improves outcomes and prevents harm. We know that trauma is common, but without this perspective, traditional approaches can unintentionally re traumatize, reduce engagement, and worsen health outcomes when, of course, we desire the opposite. So, how do you prevent re traumatization? We know that traditional approaches are authoritative, rushed, and lack transparency, all things that can trigger trauma responses. Where the trauma informed approach ensures safety, choice, and control, again, reducing the likelihood of re traumatizing the patient. For example, explaining each step of a procedure to a patient with prior abuse prevents the patient from feeling powerless or violated. We have to improve engagement and trust. Individuals with trauma histories often avoid healthcare or social services because of fear of mistrust. We have to foster trust, collaboration by encouraging patients to seek help and participate actively in their care. For example, a patient who feels heard and respected is more likely to follow through with treatment or disclose important health information than one who has fear of the system. Lastly, we have to support healing and resilience. Recognizing trauma validates the patient's experience and frames behaviors as adaptive responses rather than personal failings. This allows providers to build on strengths, empower the individual, and promote long term healing. For example, encouraging coping strategies that the patient already uses successfully reinforces that resilience. I'm sure by this point you're seeing a recurring theme of keywords and strategies such as engagement, resilience, trust, safety, etc. So these are the keys to providing trauma-informed care and developing meaningful, lasting relationships with our patients who need it the most. Improving health outcomes, right? Trauma impacts, we already said, mental, physical, social health, leading to chronic conditions, substance use, and behavioral changes. So we should address the root causes of these outcomes by providing care that considers trauma's pervasive effects. Again, research shows that trauma informed approaches reduce hospitalizations, improve adherence to recommended treatments, and lower rates of psychiatric distress. Reduce staff burnout. Providers working with traumatized populations often experience secondary trauma or compassion fatigue. Trauma informed systems emphasize support for staff, staff well being, and creating healthier work environments in general. Promote equity and cultural awareness. Many forms of trauma are linked to systemic oppression, discrimination, and historical injustices, as you could imagine. Trauma informed care integrates cultural, historical, and gender awareness, making care more equitable and reducing the risk of perpetuating harm. Lastly, shifting the focus from blame to understanding. Instead of asking what's wrong with you, again, as we said, we should focus on what happened to you to ultimately reduce stigma and judgment, ensuring patients feel respected and understood. So a lot of examples of trauma informed care violations can be seen by just turning on your TV. Medical dramas and popular TV series often depict paternalistic medicine or care that does not align with the six principles of trauma informed care. Here are some examples. In Euphoria, Rue has an extensive history of trauma. Her therapy sessions often consisted of directive therapy, where her preferences or readiness to engage were ignored. She was pressured into treatment strategies without shared decision making. In Shameless, Fiona often dealt with social workers, family social services, and therapists who dictated solutions without involving her or providing meaningful support for her and her family. She was left powerless, and her distrust of the system persisted throughout the series for these reasons. In 13 Reasons Why, Hannah's school counselors minimized her emotional distress and led with victim blaming, furthering her pre existing trauma. So, these are, of course, extreme examples, but they are things we like to avoid. So, we're going to teach you how to do so in your practice. So, trauma informed care is guided by 6 core principles, which are safety, trustworthiness and transparency, peer support, collaboration and mutuality, empowerment, voice and choice, and lastly, cultural, historical, and gender sensitivity. So we will dive a little bit deeper into each of these principles here. So safety is the foundational principle. It is both physical and emotional and underpins every interaction, policy, and environment within trauma-informed settings. So the idea is that people who have experienced trauma often live in states of hypervigilance and may perceive threats where absolutely none exist. Without a sense of safety, healing, trust, and engagement in care, it makes things extremely difficult. So, physical safety is ensuring that the environment and interactions do not expose the individual to harm, pain, or danger. Emotional safety means creating an atmosphere where individuals feel respected, understood, and free from judgment, ridicule, or coercion. Psychological safety allows individuals to express themselves, ask questions, participate in decision making without fear of punishment, rejection, or invalidation. So, why is it critical? Trauma often undermines an individual's sense of safety. Many survivors, again, live with the heightened fear and mistrust. Without a safe environment, patients can avoid care or services. They become defensive, withdrawn, experience triggers that re traumatize them. So, establishing safety is the very first step in building trust and engagement and ensuring a trauma informed environment. In our practice, environmental safety means clear, consistent, and predictable surroundings, private spaces for sensitive exams and discussions, controlled access to reduce chaos and unpredictability, adequate lighting, comfortable seating. Interactional safety is how we communicate with our patients, from the provider to the staff, all of whom should communicate with calm, respectful, and non judgmental tones, explain processes and procedures in advance, and allow patients a choice when it is possible. Should also monitor for and avoid triggers. Procedural safety, minimizing invasive procedures, allowing for pauses, breaks, or alternative options to reduce distress. Lastly, cultural and contextual safety. We should acknowledge these historical, systemic, and cultural traumas, be sensitive to power imbalances that we commonly see, right, between provider and patient, and ensure that care is inclusive and respects identity, gender, and cultural background. Some strategies that we can use to promote safety, right? Making our environment predictable, clearly explaining what will happen and when, being transparent, open communication about policies, expectations, and limitations, encouraging patients to express preferences and make choices, ensuring consistency with staff interactions, which should always be reliable and professional, and then observation, watching for signs of distress and intervening in a supportive fashion when it's deemed necessary. So examples in healthcare would be for a good clinical setting would be a nurse explaining every step of a blood draw before beginning, allowing a patient to have a support person present during exams, adjusting procedures for patients with sensory sensitivities or PTSD triggers, and using trauma informed language such as "you are in control and we can pause at any time" rather than authoritative commands. Trust is built through honesty, consistency, and follow through. The principle of trustworthiness and transparency is essential for building safe, supportive relationships between providers and individuals who have experienced trauma. Trauma often erodes trust, especially in relationships with authority figures, healthcare providers, or systems. So, our goal is to emphasize consistent, honest, and open communication to restore trust and reduce fear. But first, we must ask ourselves, what is trustworthiness? What is transparency? Trustworthiness means behaving in ways that are reliable, consistent, and predictable so the individual feels safe and confident in the provider or the system. Transparency means communicating openly about processes, decisions, policies, and expectations to avoid misunderstandings and foster informed participation. So, in short, it's about doing what you say, saying what you do, and creating clarity in all interactions. Trauma, especially interpersonal trauma, being abuse, neglect, betrayal, often undermine an individual's ability to trust others. Again, individuals may become hypervigilant, suspicious, or fearful of hidden agendas or judgment. The goal with this principle is to reduce anxiety, prevent re traumatization, and facilitate engagement. When patients actually trust their providers, they are more likely to communicate openly, follow treatment plans, and feel safe participating in inpatient care. So, how does this manifest in practice? Clear communication. Again, we should explain what will happen during procedures and use simple, consistent language free of jargon. We should provide timelines or expectations for treatment or service delivery. For example, we will take your vitals first, and it will take about 5 minutes. I'll explain each step before we begin, and you can pause at any time. Again, we must be consistent. Follow through on commitments, promises, and instructions. We should maintain predictable routines and approaches and avoid sudden changes, especially without explanation. If a provider says they will call you with test results by Thursday, they follow up as promised. Again, this is trust building. Honesty and openness. Be honest about what is known and unknown. Openly acknowledge mistakes. And avoid making false assurances that can erode trust if it is unmet. For example, I don't know the answer to that right now, but I will find out and get back to you as soon as possible. Boundaries and role clarity. So we should clearly define a provider's role and limitations. Explain that confidentiality and its limits, for example, mandatory reporting and legal requirements. We should help individuals understand expectations and to truly feel safe. For example, telling a patient everything we discuss is confidential, except if I believe you or someone else may be in danger. If that happens, I will explain the steps before taking action, which is again being transparent. Organizational transparency, right? So we should ensure that policies, procedures, and decision making should be visible and understandable. Systems should communicate rules and changes clearly to both staff and clients. For example, posting waiting room policies or clearly explaining how appointments are scheduled and prioritized should be transparent to our patients. Principle of peer support recognizes that individuals with shared experiences of trauma can provide unique understanding, validation, and hope that complements professional care. Peer support is not just social interaction, it's a structured and purposeful strategy to promote healing, resilience, and again, empowerment. Peer support involves mutual, non hierarchical relationships between people who have experienced trauma or adversity. Peers use their lived experience to provide empathy, guidance, and understanding in ways that professional caregivers alone may not be able to. It's based on the idea that someone who has been there can foster trust and connection more easily than someone who hasn't shared this similar experience. So, trauma often leads to shame and distrust, which can impede healing. Connecting with peers who understand similar struggles helps one feel validated, seen, and understood. For this reason, peer support can normalize experiences, reduce feelings of stigma, and offer models for coping and recovery. It also promotes hope and motivation, as seeing others who have healed or managed trauma successfully provides tangible proof that recovery certainly is possible. So, how does peer support manifest in practice? First, emotional and social support, providing a safe space for individuals to share feelings and experiences without judgment, active listening, empathy, and validation. For example, a support group for survivors of domestic violence, where participants share coping strategies and experiences. Also, mentoring and role modeling. Peers can serve as examples of resilience and recovery. They may guide others in navigating healthcare, social services, or just basic life challenges. For example, a peer navigator helping someone newly diagnosed with PTSD understand treatment options and access resources. Advocacy and empowerment. Peers help individuals find their voice, advocate for themselves, and make informed decisions. They can help bridge the gap between the individual and formal systems. A peer advocate attending appointments with the patient to support self advocacy and ensure concerns are heard is one example. So, peer support can exist both as informal and formal settings. So, for example, informal, casual peer interactions that provide support and connection, versus formal, being a structured peer support program with mentorship initiatives or peer counseling services. Again, the goal with peer support is to enhance trust, promote self efficacy and empowerment, support recovery and resilience, and ultimately strengthen communities, as peer networks often extend beyond the formal care setting. The principle of collaboration and mutuality. This emphasizes partnerships between providers and individuals receiving care, as well as among staff within organizations. It recognizes that healing from trauma is most effective when power is shared and all voices are valued. This principle directly addresses the imbalance of power often experienced by trauma survivors in systems of care. So, what is the definition? So, collaboration and mutuality. Collaboration is working together as partners rather than in a top down or authoritative fashion. Mutuality means recognizing that everyone, providers, staff, and patients, contribute to the healing and the care process. Both concepts emphasize shared decision making, respect for expertise, and partnership, rather than treating individuals as passive recipients of services. Trauma, again, often erodes trust and creates a sense of powerless, making individuals wary of authority figures. Shared decision making restores a sense of control and empowers individuals to participate actively in their own care. Collaboration reduces the risk of re traumatization that can occur when services are imposed without input or understanding in a paternalistic fashion. Mutuality fosters respectful relationships, improving engagement, adherence, and long term outcomes. So, how does this manifest in practice? Shared decision making, right? So, individuals are invited to participate in choices regarding treatment, interventions, or support services. Providers listen actively, offer options, and respect the individual's preferences. For example, a patient is offered multiple pain management options during a procedure and can choose the approach that feels safest for them. Collaboration extends to interdisciplinary teams as well, where providers and support staff work together with patients to coordinate care. Mutual respect and communication among staff ensure that trauma informed principles are consistently applied. For example, nurses, social workers, and physicians jointly develop a care plan while incorporating the patient's input. Equalizing power imbalances. We acknowledge that traditional systems often place providers in positions of power, which can obviously replicate the trauma dynamics. By sharing knowledge, responsibility, and decision making, providers create a more balanced relationship. For example, during therapy or counseling, the provider frames themselves as a partner. We can work together to find strategies that feel safe and effective for you. Collaborative policies and procedures. So, organizations can involve clients or peer advisors in designing programs, policies, or evaluating processes, ensuring that services meet real needs of patients. For example, a hospital including former patients in the design of a patient safety initiative to ensure comfort and dignity in procedures. This principle ensures that relationships are partnership based, power is shared, and all voices, especially those of trauma survivors, are valued. It recognizes that healing is not something done to individuals, but something achieved together, fostering trust, empowerment, and effective care. Principle of empowerment, voice, and choice is central to promoting healing, resilience, and recovery for individuals who have experienced trauma. Trauma often leaves people feeling powerless, unheard, and lacking control over their lives. This principle is designed to restore agency, validate experiences, and promote self determination. Empowerment means recognizing and building on the individual's strength, skills, and resilience, helping them regain a sense of control over their life and decisions. Voice, ensuring that individuals' experiences, perspectives, and opinions are truly heard, valued, and incorporated into the care planning. Choice means providing options and autonomy in decisions affecting the person's life, health, and well being rather than imposing these actions on the patient. So, in essence, this principle shifts the focus from doing to or fixing individuals to supporting them to actively participate in their own healing. So, how does this principle manifest in practice? So, providing choices, offering options to patients whenever this is possible, even in small matters, allowing the individual to decide how, with whom, and when services or interventions occur. For example, asking a patient, would you like to have the exam with the door closed, or is it okay if the curtain remains open? Collaborative goal setting. So, working together to set goals, identify priorities, and plan interventions. We have to recognize the individuals as an expert in their own life. So, when we talk about experts, we are referring to us as an experts in our field, but the patient is an expert in their own life. For example, what do you feel is the most important issue to focus on today? Also, strengths based approach, identifying and building on existing skills and coping strategies that the patient has, rather than focusing solely on deficits. We have to encourage confidence and self efficacy. For example, a patient who manages anxiety through breathing exercises is encouraged to use these techniques during medical procedures. Lastly, advocacy and support. So, helping individuals navigate systems, access resources, and assert their needs. This is particularly important for marginalized populations who may face systemic barriers. For example, a peer navigator helping a survivor of domestic violence communicate preferences in a legal or healthcare setting. Again, transparent communication is vital. We have to explain risks, benefits, and alternatives clearly so individuals have the ability to make informed decisions on their own. We have to avoid coercion or pressure and respect decisions even if they differ from our recommendations. Principle of cultural, historical, and gender sensitivity, sometimes called cultural humility or awareness, emphasizes that trauma is shaped by context, including a person's cultural background, historical experiences, and gender identity. Trauma does not occur in a vacuum. Systems of oppression, discrimination, and societal inequities often compound trauma. So this principle ensures that care is inclusive, respectful, and tailored to the individual's lived experience. Cultural sensitivity. It's recognizing and respecting a person's cultural beliefs, values, practices, and identity. Historical awareness means understanding the impact of historical trauma, for example, colonization, slavery, forced displacement, and systemic racism, on communities and individuals. Gender sensitivity, acknowledging the ways trauma intersects with gender identity and roles, including experiences of sexism, sexual violence, and discrimination against LGBTQ plus individuals. In essence, care is not one size fits all. Providers must consider how culture, history, and gender shape experiences of trauma and healing. So, individuals from historically marginalized groups may experience higher rates of trauma and they may be mistrustful of healthcare or social systems. Ignoring cultural, historical, or gender factors can lead to re traumatization, inequitable care, and reduced engagement. So trauma-informed care that integrates this principle ultimately promotes equity, inclusion, and respectful treatment. So how is this manifested in practice? First, cultural awareness. It's a respect for dietary practices, spiritual or religious needs, communication styles, and family structures. It avoids assumptions based on stereotypes and adapts interventions to be culturally appropriate. For example, recognizing that a patient's reluctance to make eye contact may be culturally normative rather than a sign of avoidance or distrust. Historical trauma awareness. Understanding how systemic inequities and historical events affect health and trust in services. Acknowledge the intergenerational effects of trauma. For example, being aware that indigenous patients may have experienced historical medical exploitation and mistrust institutions as a result of that experience. Gender sensitivity. Provide care that respects gender identity and expression. We should recognize gender based trauma, including sexual assault, intimate partner violence, or discrimination, and ensure privacy and safety measures consider gender specific concerns. For example, using the correct pronouns, providing gender affirming care, or offering options for female or male providers when it is possible. Policies and procedures. So we should try to implement organizational policies that support cultural competence and gender equity, include training on diversity, historical trauma, and implicit bias for all staff. For example, including culturally representative peer support groups and materials in multiple languages. Trauma often creates a sense of helplessness. Hope is the antidote. It fuels resilience and healing. Restoring hope is a critical principle because trauma often leaves individuals feeling helpless, powerless, and pessimistic about the future. Hope is a powerful component of healing. It motivates engagement, fosters resilience, and helps individuals envision a life beyond the trauma they've experienced. Restoring hope means actively helping individuals see that recovery, growth, and meaningful life experiences are possible. It involves fostering optimism, empowerment, and a sense of possibility, even in the face of past or ongoing adversity. Hope is both an emotional state and a therapeutic tool. Why does it matter? Because trauma results in this helplessness and hopelessness, low self esteem and self efficacy, disconnection from goals, community, and purpose. With hope, individuals may struggle to engage in therapy, or excuse me, without hope, individuals may struggle to engage in therapy, follow care plans, or rebuild social connections. Whereas restoring hope helps these individuals reclaim their agency, envision a positive future, and engage in meaningful action, all of which are essential to our healing. So, what are strategies we have to ultimately restore hope? We have to build on strengths and resilience, emphasize what individuals have survived and accomplished, highlight their coping skills, personal strengths, and prior successes. Right? For an example, you've managed to navigate many difficult situations. Let's explore what strategies helped you then and how we can build on them now. Set achievable goals. Right? Collaborate to create realistic, stepwise goals to demonstrate progress and capability. Celebrate small successes to reinforce this confidence. We have to provide validation and empathy. Recognize the reality of trauma and the effort required to heal. Validate emotions and experiences without judgment. Encourage meaningful engagement. Support involvement in activities, relationships, or causes that give purpose. Meaning making helps individuals feel connected and motivated. For example, volunteering, creative expression, or peer support involvement can foster a sense of contribution and hope. Use positive, strength based language. Avoid language that reinforces victimhood or helplessness. Use affirming, supportive, and empowering statements. For example, you have the skills to manage this challenge. We can explore strategies that work best for you. Offer role models and peer support. Witnessing others who have healed or managed trauma successfully fosters hope. Peers who share these lived experiences can inspire belief in recovery. Maintain consistency and reliability. Trustworthy relationships and predictable environments reinforce hope by demonstrating that support is dependable. So, again, restoring hope is about helping individuals see that recovery and a meaningful life are absolutely possible. By building on strengths, validating experiences, promoting agency, celebrating progress, and connecting people with supportive peers and communities, trauma informed care fosters optimism, resilience, and motivation, which are all essential for healing from trauma. Trauma informed environments. Physical spaces matter. Small touches, soothing colors, inclusive images, clear signage can reduce anxiety and promote a sense of comfort. Trauma informed environment is one in which every aspect of the physical space, policies, practices, and interactions is intentionally designed to promote safety, trust, empowerment, and healing. For individuals who have experienced trauma, such environments reduce the risk of re traumatization and facilitate engagement, resilience, and recovery. A couple of examples of settings that promote physical safety: clean, well maintained, and organized spaces, private areas for sensitive discussions or procedures, comfortable seating with appropriate lighting and noise control, clear signage, and accessible navigation. For example, a clinic with clearly marked rooms, a quiet waiting area, and options for privacy reduces stress for trauma providers. The images here demonstrate those findings. The image on the bottom with curtains may be an example of a non-trauma informed care compliant environment where you have curtains, where you can hear what's happening in the next room. So that may be an environment that is not demonstrative of trauma informed care. Trauma informed care must also extend to staff. Supporting staff well being prevents burnout and ensures sustainability. Staff wellness is critical because working with individuals who have experienced trauma can expose providers to secondary traumatic stress, burnout, and compassion fatigue. Supporting staff well being is essential not only for their health, but also for maintaining a safe, effective, and sustainable trauma informed environment. So, ensuring staff wellness is a multi layered approach that involves recognizing the emotional impact of trauma work, creating a supportive, safe, and transparent organizational culture, providing education and training on trauma informed care as well as self care, offering supervision and reflective practice as well as debriefing, promoting work life balance and resilience building, reducing organizational stressors, and providing access to mental health resources. Again, fostering peer support and ongoing monitoring. The bottom line is that healthy, supported staff are better able to provide compassionate, effective, and sustainable trauma informed care, creating a positive feedback loop that benefits both providers and the individuals they serve. Again, it's important to acknowledge this does not only refer to your staff, but also to you as a provider, as your self care is important in being able to provide care for your patients as well. So, our key takeaways: trauma is widespread, but healing is possible. Trust is the foundation of healing, and hope is the engine of resilience. Again, trauma informed care is about how we approach every interaction with trust, compassion, and hope. Every interaction can either re traumatize or heal, and I hope that we choose healing. I would like to give kudos to Miss Muriel Lanford, a phenomenal nurse who works with Ransom Life Texas. Her presentations on human trafficking and trauma informed care have completely changed my approach to patient care and medical student interactions. My hope is that this presentation does the same for you. Thank you for your time. I encourage you to explore resources as you continue your journey towards trauma informed practice. Here are my references, and that is all I have. Thank you very much.